Thank you, Kevin, for that excellent presentation there. Very difficult because there's no, as with most things in talks, there's no randomized trials. This is all case reports and sort of guesstimation in terms of what to do with these patients. A difficult situation, but we're always happy to help out at the Poison Center, obviously. All right. All right. So again, thank everybody for hanging out with us here. And some of you, I think, have a bit of an idea of what we're talking about here. But for those of you who don't, maybe you can chime in whenever you think you know what it is. So I think this is timely. I think they're actually debating some more of the Bill C-45, which is the legalization of marijuana. I think as we speak right now, I think it's back. The Senate has kicked it back to the House, I think, with some changes in some of the amendments that they put through. So it's not entirely clear when exactly this is going to be legal, but it will be soon. I'm not sure they're going to make the July 1st sort of date that they expected. And in terms of talking about this, I want to give you a little bit of a historical background about cannabis and some information about it, and to give you some of the lingo as well, because you might not necessarily know all that, and you want to be familiar with it. So the first descriptions of cannabis use comes from a Greek historian in 480 BC. He's talking about this group of Scythians, which were a nomadic people. It's not entirely clear where their basis was from, but he has a great description of what the Scythians did with this. They take some of this hemp seed, they throw it upon the hot stones. Immediately it smokes and gives out such a vapor as no Grecian vapor bath can exceed. The Scyths, delighted, shout for joy. So it's been around for a long time. And when we're talking about cannabis, we're talking about the family Cannabaceae. And there's basically 3 different species in this family. 2 of them, sativa and indica, are the ones that we've probably all heard about. And that's because they're the ones that actually have the stuff that everybody's interested in. And by that, I mean the cannabinoids. So there's tetrahydrocannabinol, or we'll refer to that as THC, and there's cannabidiol. Those are the 2 predominant cannabinoids in the plant. And specifically, these are phytocannabinoids, and that's going to become important because they're plant-derived cannabinoids. There's actually over 80 different cannabinoids they've identified in cannabis so far. But again, the 2 primary ones that we're looking at are THC and CBD. And as I mentioned, these are phytocannabinoids, plant-derived. And that's because there's also synthetic cannabinoids. Now, some of these we probably have seen or seen patients on. Sesamet or Nabilone, which we see people on for adjunct pain relief, is a synthetic cannabinoid. Dronabinol, which was on the Canadian market for, from the year 2000, about 2013. I'm not entirely sure why they stopped marketing it here, but it is a synthetic cannabinoid. It's an isomer of THC. There's Savitex, which actually is real THC and CBD in a 50% mixture, 1-to-1 combination, and it's spray form. And this is made by a company in Great Britain. And there's Epidiolex, which is a CBD specific drug that's in studies right now to treat some forms of epilepsy that are resistant to other types of treatment. And then finally, we've probably heard about this in the literature before, K2 or Spice. There's a whole litany of other different synthetic cannabinoids. And these were all made by chemists to basically avert the, being an illegal substance. So they created all these other synthetic cannabinoids. They bind to the same receptors, but they have slightly different actions, and we'll talk about that. So in terms of the receptors, we've got two main receptors in the body, and they're named 1 and 2 after their order of discovery. Now, CB1 is predominantly located in the central nervous system, and 2 predominantly in the immune system. From our standpoint, at least from the emergency department and the acute ramifications, we're mainly focused on CB1 effects. Now, very much like the whole scenario with the discovery of opium, its intoxicating effects, the fact that there is a specific opium receptor or opiate receptor in the body, and then finally the discovery of actually endogenous opioids, a very similar scenario has happened with cannabinoids. So these are 2 cannabinoids that your body actually makes. So same sort of sequence of events that happened. So they knew about THC and other cannabinoids. They knew it had an effect. They found the receptor, and then they were actually able to find that your body actually makes cannabinoids. And they make these all the time. They're quite diffuse. They're in a lot of different tissues. The 2 main ones are 2-AG and anandamide. Now, anandamide is Sanskrit for joy or bliss. This is actually found in chocolate and sort of maybe explains a little bit why people have some of that chocolate craving. Your body makes these and destroys them very rapidly. That's why we're not walking around high. But these are described as endocannabinoids. So we have phytocannabinoids, we have synthetic cannabinoids, and we have endocannabinoids. So getting back and looking at the ones that come from cannabis and THC and CBD, they have some differing effects. So THC is a partial CB1 agonist, okay? So it partially activates that receptor. This becomes very important because synthetic cannabinoids like K2 and spice are full agonists. So they cause a lot more exacerbated response, and that's why you see some of these people who are taking what they think is synthetic pot have a much more significant and unexpected reaction where they get seizures, they get renal failure, hyperthermia, all kinds of problems. Of course, it's got the psychoactive effect, THC does. It also has some adverse effects, so this dysphoria and anxiety that occurs, as well as paranoia and psychosis that can look quite similar to schizophrenia. And it might have a proconvulsant effect potentially as well. CBD, on the other hand, sort of modulates the effect of THC. And it doesn't necessarily bind directly to the same receptor, but it affects how THC reacts on those receptors. And this is what they call the entourage effect. This is why taking pure THC has a different effect as opposed to when you combine it with a little bit of CBD. There's a combined effect that works out there, and it sort of balances it out. It's the non-psychoactive component. It's anxiolytic. It does probably have some potentially antipsychotic effects, as well as the anticonvulsant effects as well. So you can see these are sort of a yin and yang of the cannabis plant. Now, the interesting thing is, you can't affect the content of the plant's THC without affecting the amount of CBD in it. And that's because they're both derived from the exact same chemical. So the plant can only make so much of this cannabigerol, which then it is split into parts THC and parts CBD. So, of course, it turns out that most people use cannabis because of its psychoactive effects. And the industry and the market has responded to that. And what they've done through horticulture and doing things like hydroponics and specific cultivating effects, they've actually changed the THC content of cannabis plants. You can see here what's happened to the THC content in plants. This is from U.S. drug seizure data. And you can see from 1995 to 2014 this constant incremental increase in the amount of THC that you're finding in the plants. And remember, it's got a common precursor. So at the same time, CBD is actually declining in the plant as well. And of course, you're changing this ratio of the amount of THC to CBD. So you're getting a lot more of the THC effects, a lot more of the psychoactive effects, and a lot more potentially the adverse effects in these newly cultivated cannabinoids. So just to put this in a frame of reference, This is a joint from 1960 to 1970, roughly. It's got about 10 milligrams of THC in it. So the amount of THC in a joint today is upwards, depending on which strain you're using and how they've done it, is up to 150 milligrams in one joint. So 15-fold difference. So a joint with the same concentration of THC in it from 1960 or 70 is this big now. So it's not your mama's THC. It's not your mom. It's not what your parents were using, right? So just a little bit of information, some cannabis anatomy. So there's THC and CBD found. There's cannabinoids found throughout the plant. The highest concentrations are in the flower, which comes out the end of the stems there and buds. And then on the flower, it has this very sort of glistening, sort of white, sticky substance, and this is the trichomes. Okay, this is the highest concentration of THC. This is where most of it is actually located, in that part of the flower. It actually probably serves as some sort of bug or herbivore deterrent. So it probably has some sort of protective effect, and that's why it's there. So, have you guys heard this term before? Sensimilla? Anybody have any idea what this is? So there's a great line out of Caddyshack when they're talking about how they're making their own pot, of course, and it's a mixture of Kentucky bluegrass and Northern California sensimilla. And that's what they're using. So sensimilla is Spanish for without seed. And so what they've done is they've taken female cannabis plants. They've not allowed them to be pollinated, so they can't make seeds. So all the energy of the plant goes into making the flowers and THC. So now you've got this ultra potent, buds, because they've got way more THC and no seeds in them. That's sensimilla. Keef. Man, when I did this at 420, everybody knew. So keef, this is actually the term for those little trichomes, those little glistening hairs that are on the flowers or on the buds that you can see sort of here. And as I said, this has a high concentration of the cannabinoids, the THC in it. And you can actually sort of sift these buds and flowers so that you can actually get this to come off. And this is what it looks like. It's sort of like this powdery type stuff. And this is called keef. And people actually take this, they use it, they sprinkle it on the bowl in the bong, and it's called crowning the bowl. So to give a little bit extra THC when they're smoking, or they actually take it and use it because it's sort of sticky to seal their joint, and that's called twaxing. So you can actually take this keef, and if you compress it and stick it together because of its sort of components, you get hashish or resin, which everybody's probably heard of, and it's sort of this sticky substance. And this is basically keef that's compacted together. It's got a high THC content, about 60% by weight. So you can refine this hash even further through different extraction techniques, and you come up with things like this: butane hash oil, which has been in the press, a fair amount, because if you're trying to make this at home, there's a good chance you're going to blow yourself up and cause a fire. So it's a dangerous thing to make. And also shatter, which is a different form. It's basically, depending on how they heat it and cool it, it can come out in different forms. So it can be oil, and then shatter is actually almost like a peanut brittle sort of texture, and it's stiff and it's rigid, and it can be cracked apart, and that's why they call it shatter. The other name is butter or wax. And people actually will take these concentrated things, either mix it with food or put it on their joint or whatever they're going to do, or they'll smoke this straight. So this huge content of THC, very potent stuff. And it's actually even taken into, people have actually used it and made into art forms. So they've taken these concentrated THC extracts, made them into some pretty amazing things. So what's a typical dose? So the standardized dose that we think about sort of goes back to how much THC was in a marijuana cigarette back in the 1960s and 70s, and it's 10 milligrams. And that's what most people consider sort of a standardized dose of THC. So how do we get it into the body? Of course, everybody's familiar with joints, so you can smoke it. Now, the important thing is you can't just take the live plant, roll it up, and smoke it. Well, you could, but you're probably not going to have the same effects because the THC in the live plant is not quite THC yet. It's THC acid. It needs to be decarboxylated, and that happens through a drying process. That's why people dry the buds out, because it actually changes from THC acid to actually THC. And if you heat it, then you can smoke it and inhale it. And you could do it on a bong as well, which sort of cools the smoke and removes some of the impurities. It's a little more sophisticated way to do it. And of course, then you can also vape it, which we've probably seen, and you can do this with oil or other concentrates where there's a heating element. It heats the marijuana or the THC extract just to a very specific temperature so that the THC actually vaporizes but doesn't burn, and then you inhale it. The ultra sophisticated way to do this, I guess. And of course, you can eat it as well. Probably other people can figure out other ways they can stick it into their body also, but that's probably not very common. So, THC, your body metabolizes it to this other compound, which is actually psychoactive as well. It's called 11-hydroxy-THC. It has a very short half-life. It's gone in an instant. And then it gets metabolized to what we call carboxy-THC. This is actually what we're detecting when we look at a urine tox to see if THC is there. Okay? That's what's actually excreted in the urine. So in case you guys needed a reference or an idea of use versus duration of a positive urine test, some sort of general ideas here, and this is probably a little bit conservative, but if you are a regular user, which is a couple of times a week, it might take over a month to clear your urine. And if you're a chronic daily user multiple times a day, it might take potentially up to 90 days to completely clear your urine. And that's because THC is so fat soluble and distributed in your body tissues, it just takes a long time to get rid of it. So if we look at what happens when somebody smokes a cigarette here, a marijuana cigarette. So the red line is their blood THC concentration. So it's almost instantaneous. As soon as they inhale it, their blood THC concentration goes sky high, and you can see it rapidly drops off. And then what you're left with is this sort of the solid line there. That's the that's the carboxy THC. That's what we're detecting in the urine. So you see that starts to rise, and it stays plateaued and stays in the system for a long time. So the THC level actually drops very rapidly at about the same time when the effects are starting. So at about 30 minutes to an hour, that's when the effects start. So you can see by that point in time, the THC level in the blood is actually dropped off significantly when you're having the most effect. And this is called counterclockwise hysteresis, which basically means you're getting the effect at when the blood content is actually much lower, and that's because it's now distributed into your brain. And then it rapidly goes away. That's if you smoke it. And you can see how high you get. You get blood concentrations that are quite high, 140, 150 micrograms per liter. If you eat it, you don't get near as high of a peak there, generally speaking. And there's a delay. And this becomes important. This is the kinetics of smoking versus eating are significant. And this is why things like Nabilone are dosed twice daily, because you can see you've got this gradual onset, a duration of effect of about 12 hours or so. And that's why medications like that, like synthetic cannabinoids, are dosed usually BID. And if you eat it, there's this lag time before levels start to rise and before you actually start to get effects. So maybe about 30 minutes you might start having effects, depending on what else you've got in your stomach. Those effects probably peak somewhere between 2 and 4 hours after ingestion, and they can last 12 hours or more. So it changes the whole dynamic and area under the curve in terms of what happens when you eat it versus smoking it. We'll talk a little bit about that in a few more slides. But of course, everybody wants to know, with all this, what are the side effects? What are the side effects? What are we going to experience, at least from a medical standpoint, with the legalization of marijuana? Anybody have an idea of what this is? Yeah. Thanks, Rob. I appreciate you letting me use that. So, and this is in the press, right? Did you guys see this? Eddie Lang a week ago. So, we're going to have this huge influx of, cannabis poisonings coming into our emergency departments, and we're going to be overwhelmed. I'm not sure that's necessarily going to happen. It's difficult to say. Everything is going to play out, and we'll figure it out. But I think if we look at, some of the experience in Colorado, which is where most of the robust data around legalization is. If we look at sort of the utilization rates in Colorado in 2014, which is when THC was legal and was sold recreationally, about 14% of people interviewed or surveyed in Colorado used cannabis in the last month, 2014. So here's BC's use in 2015. So now this is annualized data, so it's not quite, apples to apples. But, it almost makes me wonder, our starting point might be a lot higher than where it was elsewhere. And maybe the huge majority of people who already want to use it are using it and have access to it. So maybe we're not going to see a whole lot of change. If we look at some actual emergency department data, and this is some pediatric information, this is out of the Children's Hospital in Colorado. And anytime you're looking at data and you're looking at headlines and you're seeing all different kinds of numbers thrown around, and it depends on what your spin is, you have to remember this was an evolution. And it's been an evolution in BC as well and in Canada, where in Colorado in the year 2000, medical marijuana was legalized. Then it went 9 years, and in October of 2009, it was basically decriminalized. And then in November of 2012, they voted to make possession legal. And then January 1, 2014 is when the recreational sales came. So depending on where you're looking at your data from, you can see all kinds of different skews depending on which years you're looking at. So you can see the dark bars are the pediatric visits to the Children's Emergency Department. The lighter bars are the poison center utilization, how many calls they got per year about marijuana. So you can see there's an obvious trend here and an obvious difference. But if you look at the actual y-axis, look at the total number of cases that you're actually looking at. There is a change, but it's not massive. If you look at absolute numbers, you're only looking at, maybe a dozen cases difference a year, at least in pediatric visits. And if you look at Colorado in total, and you look at their whole emergency department visits, and this is patients or visits per, marijuana exposure related visits to an emergency department per 100,000 emergency department visits. So it's scaled. You can see it went from 800 to 1,100. And if we look at that in terms of our, how many patients we see at St. Paul's, if we had the same trend here, that would equate to probably about 2.5 extra patients per month that we might see, just in rough numbers.
So interesting, because of that story with Eddie Lang, communication people these days ask me about our regional visits for marijuana, well, for marijuana related psychosis. We don't have data, but I did look at information from the region around the diagnosis of marijuana classification. We saw 319 cases in the region. Most of those were at St. Paul's, but
And on 420.
50% of those visits came on one day.
Yeah.
420.
Yeah.
Which makes you wonder about the relationship with edibles and all that stuff.
Yeah. And we're going to talk about that. So, yeah. And if you talk to the guys, people in Colorado and where the problem lies, it's hugely with edibles. And I think everybody who's worked here on 420 also recognizes this. The huge majority of our patients we see are people who've ingested it, right? And it goes back to this pharmacokinetic profile. You've got somebody who's a naive user who has some cookie or a lollipop or whatever, where there's no indication whatsoever how much THC is in it or what a dose is. Is it the whole cookie? Is it one bite? Is it one chip? Nobody knows. And you've got a naive person who takes a bite. They don't feel anything because they're not going to start getting effects for about 30 minutes, and it's not going to peak for 2 hours. They end up eating the whole cookie or the whole pile of brownies or whatever, and now they've got a massive depot of THC sitting in their gut. So you can think about somebody trying to get that much THC into their body smoking. Eventually they're going to get so high they just can't do it, right? So it's self-limiting. But you can ingest a whole heck of a lot more. So the edibles are probably way more the problem, just because of dose. Yes? So if we look back at Colorado information, though, we saw that there's an increase. But they went back and they looked specifically at whether this is people from Colorado or whether these were sort of marijuana visitors, right? And you can see that the huge majority of these cases that they were seeing in terms of an increase were from these out-of-state visitors, right? So these sort of marijuana vacationers. They were coming in. They probably weren't used to the fact that the Colorado THC is so potent and much higher THC content than the other cannabinoids they're used to. They're probably coming for, it's sort of like Vegas, they're coming to party. People get out of control in Vegas. Same thing probably happened there. And remember, in Colorado, there's a huge number of overall users that are also using them medicinally, not necessarily recreationally. So it sort of makes sense why you see this huge influx. And, one of the University of Colorado hospitals is actually quite close to the airport, and they get a huge number of people coming in, who are exposed to this. And it's not necessarily somebody who just flew into town. What they're actually seeing is somebody who's on their way to leave, and they've got their cookie or whatever's left. They can't take it with them. So before they go through security, they're going to polish it off, right? So yeah, they see a lot of visitors from that standpoint. All right. So we can't get through this without
shit, man. I never had no dope like that before in my life, man. That's the heaviest shit I ever smoked, man. I mean, I smoked a lot of shit before, man. But goddamn, man, that's heavy shit.
You okay?
I can't breathe.
What's the matter?
I can't breathe, man.
Well, here. Hey, man. Hey, I got something to mellow you out, man. You're just freaking out. Here.
I never smoked no shit like that before.
Take these,
what?
Man. Take these. This will mellow you out, man.
What is that, man?
Let's take them, man. Oh. Hey, don't take those, man.
What?
I almost gave you the wrong shit, man.
Hey, man, I already took them, man. Hey, what do you mean?
Wow, man.
Hey, what was that shit, man?
You just ate the most acid I've ever seen anybody eat in my life.
Hey, man, I never had no acid before, man.
I hope you're not busy for about a month.
I'm gonna die, man. That stuff's gonna make me die, man.
No, that's good acid.
Hey, man, I never had it before, man. That's gonna make me die. Well, it's gonna make me freak out, man. I seen those guys that walk around my neighborhood had too many acid, man. Their head looked like a pumpkin like that, man.
Wow, relax, man. Hey, mellow out, man. Now just go,
What?
Do it, man.
Shit.
Mellow.
Man.
Mellow. Yeah. You better now, man?
Yeah.
You mellow? Yeah. Feel all right, huh?
So, it's an example of sort of the psychosis and the paranoia that somebody might experience. So, and this is not new. So, this is a book from 1845. This is a French psychiatrist who published this book, and he basically talks about the psychotic effects of cannabis. Acute psychotic reactions, generally lasting but a few hours, but occasionally as long as a week. The reactions seem dose-related, and its main features included paranoid ideation, illusions, hallucinations, delusions, depersonalization, confusion, restlessness, and excitement. There can be delirium, disorientation, and marked clouding of consciousness. So this has been known for hundreds of years in terms of what its potential effects are. And of course, this is, what everybody's sort of worrying about and what the headlines were talking about in terms of the psychosis that might be related to THC and what we might be experiencing, especially because of the high potency and high THC content that we see in this. So if we actually go back, Colorado actually has some data about visits that had a combined diagnosis of, marijuana or THC and a psych-related visit. And you can see here in the red line, here's what it is. So there was a bit of a change. At least they could see some of it, but not dramatically again. So when we're talking about psychosis related to THC, there's basically three flavors, and this was a little bit enlightening to me to realize this and to learn about it. So there's a bit of a table here. Basically, the first type is what we call this fast on, fast off, where this is somebody who has immediate symptoms. They get psychotic, they get paranoid, they get all this stuff that happens immediately after use. The symptoms last for hours. You generally don't need to do a whole heck of a lot, and they get better. We've all seen these guys, you know, or seen this person. Some visiting student from another country in their first trial of using marijuana, and all of a sudden they develop paranoia, and they show up in the emergency department. You kind of settle them down, mellow, and you let them chill for a little bit, and they're better, and they go home. We've all recognized that. It's not really a whole lot of time or our effort involved with taking care of these. Now, we've got this other sort of unfortunate and recognized group as well. These are the slow onset and persistent symptoms. This is the whole idea behind, can THC or marijuana use trigger psychosis or reveal it in somebody who has a propensity for it? And these are patients that use it chronically for long periods of time, and they gradually develop psychotic features. And then it can be quite permanent or last for a very long period of time. It's very slow to go away, maybe weeks or never, and oftentimes they need some sort of usually psychiatric or antipsychotic medication involved. So I think we've seen both of these groups here at St. Paul's, and I think these, from our standpoint, are relatively easy to deal with. One's going to go home, one's going to see psych. It's pretty straightforward. There's this third group, though. And it's probably less well understood, but this is the fast on and slow off group. This is somebody who smokes or eats or something, and they get symptoms right away. But their psychosis lasts way longer than what their intoxication period should last. It lasts for that days or a week period of time that was described back in the 1800s. And this is a curious group. They're starting to look at this group a little bit more intently, and they think that there's probably, if these people continue to use, they probably have a 30 to 50% likelihood to go on to be in that permanent state group, to have permanent psychosis. So this is a group that we could potentially intervene with in terms of counseling and saying, look, your risk of going on to having permanent symptoms if you continue to use is exceedingly high. These patients may or may not need some sort of intervention. Now, there's no easy answer in terms of how do you treat these guys. What do you use if you need some sort of antipsychotic or medical treatment for them? If you talk, now the huge majority of these patients are actually, they're going to be a younger group, right? And if you talk with our psychiatrists, especially the ones who do a lot of the youth sort of psychiatric stuff, they do recommend that rather than using high-potency antipsychotics like Haldol and Loxapine, that you use the newer antipsychotics, the lower-potency ones. And each person probably has their different take on it. It seems like most of them seem to like risperidone, in a 0.5 to 1 milligram dose. Because it's got probably some more antipsychotic effects and less sedating effects at these low doses as compared to like olanzapine or quetiapine. But there's no established guidelines specifically on how to take care of this group. It's just a group that you could potentially intervene in.
Is that a reveal or is that a cause?
It's good. Yeah. If people...
If they stop marijuana, they're still going to go on.
Yeah, I mean, they think that if they continue to use, they may go on, but it's difficult to suss that out. I don't think they have enough information to say that they definitely would or would not, but they do say, if they continue to use, there's more of a propensity that they're going to go on to have this. Now, the numbers aren't, absolutely solid or great. There's just sort of a guesstimation here, and it's not entirely clear still whether it's a chicken or the egg effect, right? Whether people are smoking to mask some of the psychotic symptoms that they've got already developing, or whether the actual smoking and a certain propensity causes them to go on. I think it's still yet to be defined.
Chris, do you know what risk factors? Is it age? Is it sex? Is it pre-existing illness?
Certainly age. And so the two things that seem to be the thing that recurs is age of onset, so using earlier, so starting in your teen years, and the amount of use too. So the more you use, the greater your risk. There's probably a dose-dependent effect there. Beyond that, I don't know any of the other specifics that I was able to glean from that. Okay, so what's the mysterious illness? So, I mean, the press loves this stuff, right? So we've probably seen these patients, these cannabinoid hyperemesis or cyclic vomiting people in respect to marijuana use. And again, if we go back and look at Colorado data and look at the information that they've got related to this, so here's their statement. They saw a doubling in the number of cyclic vomiting visits after legalization. A doubling. So it went from 41 per 100,000 visits to 67. So again, there is a change. There's a definite change. I mean, anytime you've got more of something that people can be exposed to, you can anticipate some changes. But in absolute numbers, it's not huge effects. It's quite possible it could be that people are becoming more aware because it was first described in 2004, and maybe people didn't quite recognize that this was a true entity before that, right? So that's a good point. So there's no ICD-9 or ICD-10 code for this, or definitive diagnostic criteria, but there's suggested diagnostic criteria that sort of keep reappearing in these case reports and observational studies. So it's usually at least weekly cannabis use, tends to be more than that, daily or multiple times a day, typically for more than a year. So there is some sort of dose-dependent effect. Severe nausea and vomiting, of course, and often with abdominal pain. This is typically what we see. If they actually stop using, all their symptoms go away. If they resume using, their symptoms come back. The compulsive hot shower or bath, they seem to find some relief with. Those are the things that are sort of recreated and very frequently in these observational and case report studies. So this is the main things you might be looking for. So asking about the shower and bathing thing is another thing to think about. And the other thing, there seems to be probably a male predominance, a younger onset. So typically these are not 50-year-olds you're seeing. They're younger people. They're oftentimes the median age of onset is around 24, and typically they've been using since the age of 16 or so. So again, it's a risk factor in terms of duration of use. And their symptoms seem to be worse in the morning. So I'm just thinking back, a couple of our patients that often show up, and I think maybe I would think that they tend to show up more often in the morning. I'm not sure what you guys think as well. And in terms of treatment, so basically a recent systematic review of all the literature and looking at what seemed to work. There's no grade 1 evidence for this, so at best it's grade 2 evidence. So you do your standard stuff. You give them some Gravol, some metoclopramide, some ondansetron. It typically doesn't work. So what's everybody's next go-to? So actually, benzos seem to have a greater effect than Haldol, at least in looking at all these cases. And the idea is that somehow THC modulates the GABA receptor and causes some sort of adverse dysregulation there. And if you give some benzos, it often may settle their symptoms down. So this may be something else you would try instead of the Haldol, at least first. Now, Haldol is sort of the third-line therapy, and specifically Haldol, not other antipsychotics. And it may be because Haldol has more of an antiemetic effect. Specifically, Haldol seems to be the other thing that might be of use. And we've all heard of capsaicin. So this grew out of the idea of, why is heat good for these people? Why do they like hot showers? Well, if you put capsaicin on, it feels hot, right? It's this burning sensation. It's derived from a chili pepper. And if they actually look, you can see there's a receptor that capsaicin actually binds to in the body, and they're often found in close proximity to the CB receptors. So there may be some sort of dynamic that plays out there. Now, oftentimes they recommend putting on the abdomen. Now, you can put it anywhere on your body. Obviously, you probably want to avoid sort of the more sensitive parts because it'll get absorbed through your skin no matter what. There's probably some sort of psychological component to actually applying it to the abdomen, though. And we actually have it in our pharmacy here, so you can try to get some up from them and use it if you're really stuck. Yeah. Just don't get it in your eyes. Wash your hands before you go to the bathroom after using, stuff like that, common sense sort of things. And the final thing is, and this is not for acute treatment, this is more for prevention. They think low-dose TCAs in these people actually may help prevent recurrences. All right, let's shift gears and talk a little bit more about kids. So they're not generally going to be exposed by smoking. There is, sort of this secondhand smoke phenomenon, but that's not going to make them intoxicated. So this is an example of resin or hashish. You can see this looks a lot like chocolate. I mean, you can see why a kid might walk by and eat something like this. High concentration of THC in this. You can imagine a little kid taking this. But, the edible industry is exploded. I mean, these are just a few examples of I mean, what kid is not going to go after that, right? Gummy bears, all kinds of knockoff, candy bars and ice cream sandwiches, drinks. And I was absolutely astounded, too. There's even a barbecue sauce. So you can see why kids might be drawn to some of this stuff, right? And so and they've recognized this in Colorado, where they've seen the effects of increasing number of visits, although not huge numbers. So they're making some changes, and these will come into effect this year. Where actually, what has to be done is every single standardized single dose, which is 10 milligrams, has to be marked, or the individual dose package has to be marked with a symbol basically like this. Okay. And this is not just to help with kids, this is to help with adults too, in figuring out how much they should take, right? Because what's the dose in that chocolate bar there? Nobody knows, right? So this is a little bit more clear, okay? So those are all individual doses. So each of those should have 10 milligrams of THC in them. So besides that, you've got to have some labeling. You've got to have a child-resistant container. It can't be sort of marked as candies, or ideally not appealing to children. And the other thing they did is they set a limit on the maximum amount of THC that can be in the product. So just in case somebody screws up and they eat the whole thing, they're not really going to they're not going to get like a gram. So if kids get exposed to this, what can you expect? So this is about 3,600 cases reviewed in the literature here. And this was the common things that they found. So lethargy and ataxia. They look sort of drunk, right? Sometimes they have tachycardia. There was a fair amount of kids that they noticed sort of had decreased tone and maybe some big pupils. Okay? Not that big of a deal for the most part. Few kids had seizures, and a very small number actually required some airway intervention. They actually needed intubation because of their their lethargy and their respiratory status. A lot of them had extensive workups, blood work, CTs, LPs, all this stuff. And a lot of this is probably because of the fact that people didn't divulge it and people didn't suspect that this was something that they were dealing with. They came in with a floppy kid with no history of ingestion. And so they got a huge workup. Most of these kids were better within 24 hours. A couple of them stayed maybe up to 5 days. So it's a short-lived thing for the most part. And if you actually look at what they did in terms of looking at data, again, from Children's Hospital in Denver, you can see that right during the start of when there was this legalization period just coming into effect, about 3 out of 16 or 20% or so volunteered that their kid got into it. The caregiver informed the team that they actually got into this stuff. And you can see a huge majority got a medical workup beyond a urine drug screen. Now, as they got a little bit more familiar and people were a little bit more willing to divulge that their kid got into stuff, you can see the changes here. Now, you get over 50% saying, yeah, my kid got into this. Now, in some cases you may not know. And then, of course, the medical workups dropped. And I think they got more familiar with seeing this. And so I think if you've got a kid who presents sort of like you would expect and otherwise seems okay, and you've got a positive urine drug screen, that might be all you necessarily need to do. Sort of depends on the clinical scenario. But for the most part, they're going to get better within 24 hours. All right.
I think it's even better than before,
I wonder what Great Dane tastes like, man. Wow, man. That's some heavy shit, man. Hey, man. Am I driving okay?
I think we're parked, man.
So this is the huge debate now. So Bill C-45 was the legalization of marijuana. There's another bill, too. There's C-46, which is actually tabled right now. And this has to do with amending the basically the driving while intoxicated laws. And it's yet to be seen exactly what's going to happen with this. Now, with alcohol, it's often pretty straightforward. So this guy actually got arrested for a DUI after he flipped his car. And with alcohol, like I said, it's pretty straightforward. And we've got years and years and years of study. And we can see that there is a definite risk of crashing the higher, your blood alcohol content goes. And, it's a little bit different in BC, but the federal level and what's legal in the United States is this 0.08. You can see where this crash risk starts to escalate right at that point, okay? So that's the legal level. And what they call that is the per se level. And that basically means it doesn't matter how you're acting, what you're doing, anything like that. If you've got that much alcohol in your system, you're drunk. And that's, a DUI charge, right? And even if they arrest somebody or pull somebody over on the side of the road and they have suspicion this is going on and they need to get confirmatory testing, it takes an hour and a half, 2 hours to get blood work done or get somebody back to the station or somewhere they can do it. You have a relatively easy means of calculating where they actually were at the accident within a fairly, close range of certainty. And that's because of the way that alcohol is metabolized. Now, we do this all the time, every single day here in a forward fashion, right? What's their alcohol level? When are they going to be sober for psych? Right? You're doing it in a forward fashion. From a medical legal standpoint or from a legal standpoint, they're going backwards. And that's because alcohol is metabolized essentially in the same fashion with everybody. It's what they call zero-order elimination. That means it's the same fixed amount that your body eliminates over a fixed period of time. So with marijuana, it's not like that. So, and this, we all probably seen charts like this in terms of how much can I drink before I'm drunk? How much can I drink before I'm legal? How long do I need to wait before I can drive? Again, with marijuana, we don't know that. So here's an example, again. So you see alcohol there in the red line. This is what happens to the elimination of THC in your body. It's got first-order kinetics. So it drops off rapidly. And we saw that before here. So you get this huge spike right after you inhale it. It drops off very rapidly and then goes away. So you can imagine if somebody was pulled over or arrested at hour, say, 1 or 2, by the time an hour and a half or 2 hours has passed and they actually get a blood level, their THC level is going to be declined, fairly significantly. So it's complicated in terms of figuring this out from a driving standpoint. And that's because there really is no universal definition of a blood level that defines impairment. Now, some jurisdictions have used different per se levels, and this 5 nanograms, which is equivalent to 5 micrograms per liter, they're actual same amounts, just sort of different measurement numbers there, depending on who you're reading. Just don't get confused with those. They're essentially the same. So in Colorado and Washington, they've used the 5 nanogram cutoff in terms of defining when you are intoxicated. There's this sort of intoxicated light range, like this 2 to 5 range, where they think that there may be some sort of degree of impairment, but not quite to the degree of 5, but nobody still knows. And the difficulty, again, arises because we're looking at blood levels here. This was all done in experimental situations where they've got somebody in a driving simulator and they're actively drawing their blood. That's not what happens in real life. So they're trying to figure out, how can I at this roadside be able to sort this out to see, you can get somebody to breath to see what they are with alcohol because it correlates very closely with their blood level. So actually, if you look at saliva, it mirrors quite closely to what you see in the blood. At least if somebody smokes, they're going to have a huge amount in their saliva relatively quickly, but then it'll drop off and pretty much mirror what you're going to see in the body. And so this is probably what's coming. where they're going to have this roadside sort of saliva test for the amount of THC in your body. It's yet to be determined whether that's definitively going to be the case and which product. I don't know if you've got an in or a way to figure out, which company is going to manufacture this, because they're pretty pricey. Might be a good stock option for you. The other thing that really is difficult is if you got somebody who uses chronically and you use in high amounts, and then you take them away, they abstain, so you can get levels above that for several days after they've no longer been exposed. So it makes things a little bit more complicated. They may still have some potential sort of intoxicating effects even at that point, but this group, I think, is still yet to be defined. What I can say is that if you mix marijuana and alcohol together, they at least have an additive effect and probably a synergistic effect. So the sum of the two is greater than, equivalent parts. So if you're getting high and you're drinking, you're probably going to be a lot more inebriated than what you would have done with equivalent amounts of either one of them. So going back to this Bill C-46, the draft of this right now is basically talking about a per se limit of blood THC, which will probably, I'm guessing, is going to be that 5 nanogram cutoff. There's probably going to be limits, too, in terms of where you fall if you have both alcohol and THC in your system. And then they're going to have this low concentration level, this is not truly a DUI, but this is a fine. This is probably going to be in that 2 to 5 nanogram range. This is sort of what the draft is. But I think a lot of this is going to be yet to be defined, and it's going to play out over years in terms of courts and what's going to happen with defining what's truly intoxication and what's not. Because right now it's exceedingly difficult just because of the kinetics of THC versus alcohol. All right, so we'll just finish up here. So there's probably going to be some change in terms of the number of hospital or medical exposures related to this legalization. It'll probably depend on where you're at and what your starting point is and how close you are to a border town that doesn't have legalization and getting visitors. So it'll probably vary throughout the country and city to city. Careful with the edibles in terms of how you dose them and leaving them around kids. So, like I said, with the kids, if you've got a positive screen and you're not worried about something else, that might be all the workup you need to do for them. There's the 3 flavors of psychosis. One we might be able to intervene and maybe have an effect with. And the effects or the problems and issues with driving, I think, still need to be determined. All right, any questions? Yeah, there is, and there are some papers detailing the kinetics of that. There's not very many of them, and I didn't look at great depth of them, but I know some of it can be absorbed. Yeah. All right, go for it.